first question. Lately, it seems that there's an increasing push for psychology and psychiatry to be more like the biological sciences and to think about mental disorders as brain disorders and problems of brain chemistry. Given what we know so far about the biological basis of mental illness, do you think it's meaningful or productive to talk about mental disorders in biological terms? Please, if you can, discuss whether doing so is scientifically justified, helpful in explaining and understanding mental disorders, or reflective of how psychiatry should ideally be as a field. Professor Horwitz, can you get started?
Sure. Well, first let me thank the Pomona Student Union for sponsoring this event, and also especially thankful to Yi, who's amazingly efficient in organizing us. And I don't know if A. Cass is here.
Hi.
Thank you as well. So, but just to get started with the first question about the usefulness of viewing mental illness as a problem of brain chemistry, I think, well, first of all, in terms of the current matrix of the sciences, it's almost impossible for really any scientific field not to take into account the brain, so that it's going to be very, very important that psychiatry and other mental health fields, and almost inevitable that they're going to be doing that. But what I think is most important and possibly most overlooked is that all human actions and behaviors and emotions are somehow connected to the brain. That is, it's not just mental illnesses that are brain connected and normal behaviors aren't. That is, both normal and disorder behaviors in some senses are connected to brain-related activities. So that just showing that some condition is related to particular neurotransmitters or to particular brain regions doesn't really say anything at all about whether that behavior is a mental disorder or whether it's a natural behavior. That is, many think to get anxious when we're in dangerous situations, or to be anxious when things are uncertain for us, or to get depressed when we've suffered losses of some sorts. Those are undoubtedly brain-related, but they're the way that the brain is naturally designed to work. That is, so that anxiety in the face of danger or depression in the face of sadness isn't a mental disorder, although it can be brain-related. So I think we have to go beyond just saying that some condition is brain-related to really do the work of trying to decide, well, what kinds of behaviors should we diagnose as mental illness when brain functioning isn't working properly. And that, I think, that psychiatry really has a considerable way to go before we really know what sorts of brain functions are dysfunctional, not working the way that they are designed to work, and which ones represent appropriate brain functioning. And just to finish up, I'll say, but it's also very important to realize that the brain is only one of many different factors that produce both mental disorders and natural behaviors. There's personality factors, there's life history factors, there's social factors, so that exclusively focusing on the brain certainly would be a major mistake.
Thank you. Dr. Peele?
First, I want to thank Leah for having me at this meeting discussion. Secondly, I was 3,000 miles away, and the further the speaker comes to address a group, usually the greater the esteem of the speaker. And so I assume that you folks will all believe the fine things that he said about me. I also want to say that another plus for me is getting a chance to read Allan's book, and Creating Mental Illness. I strongly recommend it for those who would like some background and on how the DSMs have evolved. Relative to the basic question, I think it is an error, and it's been an error for a long time, to see mental illness as brain disorders, because the psychiatrist, psychologist, and anybody else treating people with these problems should be using concepts that help the patient. Whether a concept is true or not is not the basic question for the clinician. The clinician will have concepts that will get her or him through their work with the patients. The concepts that a given clinician may use may be off the wall in terms of whether it's true or not, but it might be quite effective in that therapist's hands. For example, nobody's ever found the id, ego, and superego in the brain. It still remains that there have been clinicians in this country that have used that concept to help many, many patients. So the key for a clinician is not the truth. The key for the clinician is what concept helps that clinician help the patient. Now, the concept that mental illness and brain disease are equivalent has been around for a long time, and in 1850, a German psychiatrist named Griesinger championed it. It was very unfortunate because it put the dash, in a sense. It made a number of very therapeutic approaches seem unscientific. Only in the 1980s, when it became accepted that events can change the brain, where then we opened up to the fact that psychotherapy, etc., can be as useful as medications.
So hello. I just first want to say what an honor it is to be here. How just jazzed I am that I'm sitting next to the Secretary of the American Psychiatric Association, some of the SSRIs meetings. This does not normally happen. You should know, actually, that there's a whole bunch of people right now who are very excited that I'm in this room right now. So, brain chemistry. Yeah, so I don't know if you've ever heard the phrase, I think it was Abraham Maslow who said, if your only tool is a hammer, everything looks like a nail. That's a really good way of talking about modern biopsychiatry. And now I think that there's a way that we can talk about brain chemistry, and it's almost as if the philosopher Lacan talks about the particular human ability to be able to deceive by telling the truth. But you're telling the truth, and that's just one little part of the truth, and then there's all this other stuff going on. And I feel like talking about brain chemistry when we're talking about mental illness and talking about the ways that people stay healthy in this world is leaving out huge sections of what makes people mentally ill. Really, the main thing that makes people mentally ill is poverty. The things that actually cause suffering in this world. We can talk about brain chemistry. Of course, the brain has some function, but I will tell you right now that, as someone, I'm the one person on this panel who's actually diagnosed with a psychiatric illness. I'm diagnosed with bipolar disorder. And I've spent a bunch of time locked up in psychiatric hospitals over the years, and I'm part of an enormous community of people who challenge this whole idea that we should even be talking about brain chemistry, because there's so many other more important things to be talking about. If I was just going to answer the question in a straightforward way, I'd say NAMI, the National Alliance for the Mentally Ill, which is the largest advocacy organization for people with mental illnesses in this country, had a campaign some years ago. Maybe some of you are familiar with it. It goes something like this. People who are diabetic take insulin, and people who are clinically depressed should take an antidepressant. And you know what? That is filtered into the popular culture so much that there's all these people that actually believe this, and when it's actually just metaphors, like the doctor said right here. If it works for a clinician to say it, then that works. But they're just a bunch of stories. Do we really know what's going on? So of course brain chemistry has something to do with something, but that's not the interesting conversation to have. Thank you.
Professor Horwitz, would you like to respond to anybody?
Well, I'll just pick up on something really that Dr. Peele said that I think was very interesting, which is that when patients or clients believe that a mental health professional has something to offer them, and using the example of the ego, the id, and the superego, that those concepts can help them. What I really think is interesting now is that so many people believe in the concept of chemical imbalance and brain chemistry that that may not have in fact, a more important impact on how people are really feeling, or the reasons for their distress. But as long as people are believing that their brain chemistry has an effect, then it will have, can have a very powerful impact on, especially the effectiveness of different kinds of therapy. And probably belief in a certain set of ideas, and these ideas are always going to be strongly culturally influenced, is going to be a powerful determinant of how effective any treatment is going to be.
Dr. Peele?
The concept that the brain's chemistry needs to be changed, it's certainly a concept that many physicians have used, including psychiatrists, but a lot of primary care physicians also have used to encourage patients to take their medications. But there's no abnormality in terms of chemistry that anybody's ever spotted. Furthermore, the medications are going to do anything. They're going to make the brain's chemistry abnormal. So it gets back to the point we made before, that is, and taking on what Allan is saying, does the concept in that physician's hands help her or his patients? Now I think that, and Allan will probably give a better explanation than I can, I think in the 1980s, for some reason or other, the concept that you're suffering from a brain chemical imbalance and the medications is going to help you attain that balance was a popular approach that many physicians used relative to their managing patients. And it is also true that NAMI, Major Advocacy Group, I'm glad Sascha brought it up, contributed to that concept's popularity. I think in 2012, though, it is less attractive, and I suspect that physicians are using the concept less often. We don't want the patients or the field to think that events are not just as important as medications relative to changing the brain.
Yeah, I feel like, I mean, just responding to the comments, on some level, I feel it's like you can have a conversation, and the conversation can be happening in a closed loop, and then if you step outside that loop, you realize that there's a big world out there, and there's all these other things that are impacting it. So I just want to reiterate that we can talk about the concept of brain chemistry, but there's all these other social factors that are taking place, and I just, and there's questions that, we'll get to, I'm sure.
Yeah, we're actually going to move on to those social factors now. So scholars have speculated for decades that some or even all mental disorders are caused by societal factors more than by anything about the patient. Today, how do the norms and values of our society come into play when defining what we consider mentally ill? Do you think it's possible to completely eliminate the influence of society, or are there circumstances where that influence is actually beneficial? Professor Horwitz?
Yeah, well, unquestionably, I'm a sociologist, so you have to believe that social factors are very important. And what I find perhaps the most interesting aspect of recent developments is how really the notion of having a mental disorder now is in the positive interest of so many different groups. That is, obviously, mental health professionals require mental disorders, or they won't have a living. I mean, they only get paid if what they are treating gets called mental illnesses. As insurance companies are only going to reimburse them for if they treat disorders, not if they treat normal behavior. Likewise, people who are suffering, people who are distressed, often can't get treatment unless they have a label of some mental disorder. And often, especially parental groups, oppose, say, efforts of the DSM-5 to narrow definitions of Asperger's and autistic disorders, because if the condition isn't called a disorder, they can't get the kinds of social services that are associated with the disorder. So they advocate in favor of having disorders. Pharmaceutical companies can only market their products for the treatment of a disorder. So they have to call the conditions that their drugs treat mental disorders. Or funders of research only can get money, and researchers can only get money for studying mental disorders. That is, you can't now say, well, I'm interested in studying psychosocial problems. You say what you're studying is just a social problem. It's going to be really hard or impossible to get money to study it. So, but if you say what I'm studying is a mental disorder, it's a lot easier, it gives you a lot more capital to say if what you're looking at is a mental disorder. So in our society now, calling something a mental disorder is really in the interest of many different groups. Calling something just normal behavior, normal responses to social environments is not really in the interest of very many people. I think that's one major reason why we seemingly have so much mental disorder in our society now, because it's in the interest of many groups to have. And it's not in the interest of many groups to have normal behavior.
I think being in a university setting, with a group of people who are interested in the truth. And I think for somebody like myself to come in here who is more interested in what is clinically effective may sound very foreign to you. But that the clinician is interested in what can be helpful. Now, Allan is correct, I think, that there are a lot of factors that lead to people having psychiatric illnesses. I think Sascha is quite right about poverty. But the issue for the clinician is not this truth. The issue for the clinician is, how can I help this person in front of me? Can I change what leads to poverty? Can I change the social factors? Usually not. Let's look at pneumonia. Now, I go along with Sascha. Pneumonia is more likely to occur in people who are in a poverty state. There are a lot of social factors that lead to people having pneumonia. We could have some very thoughtful, etc. comments about what causes pneumonia. But how do you interrupt the process? You're interrupted by very late stages of giving them an antibiotic. And the psychiatrists and the sociologists, the psychologists and the social workers who work with, and the nurses who work with the mentally ill have the same issue. The person in front of them is distressed or disabled. How are they going to help them? The question is, where can you interrupt it? The question of whether the cause is good in terms of interest in prevention. But if you're going to help the person in front of you, you have to try to answer, where can I interrupt? And that interruption may not be related in some ways to cause. The medications are not tied to cause. Some of the psychotherapies are not tied to cause. And yet, they can be very helpful.
So the analogy of antibiotics is interesting, because I think it's a good one. I mean, I feel like antibiotics would be an example of, these are drugs that save a lot of people's lives, and and then because of the particular kind of economy that we live on, they're completely overprescribed. And so way too many people end up taking antibiotics. I would say that antidepressants fall under the same category. You know, these are drugs that save lives, and then they're completely overprescribed because we live in a society that, you know, that there's profit motives in a way, and there's not the social safety nets to be able to catch people. So yeah, sure, if you're a psychiatrist, like I said, if your only tool is a hammer, everything looks like a nail, right? I mean, I think it's really important when we're talking about this stuff to step back and look at the historical picture. I mean, in 1980, when the DSM-3 was published, it was at the same time, we were just having this conversation about Ronald Reagan before over dinner. You know, Ronald Reagan came in 1980 and slashed the social safety nets. I mean, there was this rise of what people in my community call neoliberal economics. I mean, of the forces of basically creating, you know, whatever was left of social systems and dismantling them. And that just happened to coincide with the rise of the biopsychiatric model. I mean, it just, you know, there was the, at the same time that Prozac came out, you know, and there was suddenly this flood of marketing. Yeah, it was convenient that, you know, we as a society we're moving more and more towards an individualistic, you know, model of thinking about people. Here, I have this great quote from a psychiatrist in the UK named Joanna Moncrief. The quote is, she's like one of my heroes. A society that is increasingly socially fragmented and divided, where the gulf between success and failure seems so large, where the only option to many is highly demanding and low-paid work, where the only cheap and simple route to carelessness is through drugs, is likely to make many people particularly vulnerable to mental disintegration in its many forms. It has long been known that urban life and social deprivation are associated with high levels of mental disorder. Neoliberal economic policies are likely to further increase these pathogenic effects. By medicalizing these effects, psychiatry helps to obscure their political origin. The social catastrophe produced by neoliberal policies has been washed away and forgotten in a language of individual distress.
Would you like to respond? Anyone? Comments?
Yeah, well, actually, I think Sascha brought up Joanna Moncrief, and Dr. Peele had mentioned that the clinicians, their goal is to help people with whatever resources are at their disposal. And one of the biggest findings, and actually Joanna Moncrief is one of the major researchers in this area, that I find truly puzzling and would like to hear what other people think, is that the SSRIs, which are the most commonly prescribed psychoactive drugs now, used for a wide range of depression and anxiety, eating disorders, substance abuse disorders, almost the whole range of conditions in the DSM. But most of the research that uses, say, double-blind experimental trials shows that aside from the most serious conditions, that these drugs don't seem to be more effective than placebos. And the question, though, to me is, you know, how can that be true? We have so many millions of people who are taking these medications. Are they being fooled? You know, are they dupes of some kind? It seems to me that they truly believe that they are being helped. I mean, so that there seems to be a disconnect between the research on the effectiveness of the most common kinds of medication that doesn't show much effectiveness, yet the belief, not just of clinicians, but also, I think, of people who are taking these drugs, that they are helping them. So I would love to hear how to resolve that dilemma, which to me is a real puzzle.
That's a very good question. Thoughts, Doctor?
Allan is right.
I didn't mean to put you on the spot.
Oh, no, I was just wondering whether I should bring out a prescription pad and give everybody. Anyway, no, Allan has brushed a number of topics, and I guess I just want to address one, because it does get closer to home for some of us. The relative to the managing depression, Allan's right. The antidepressant medications are used for a dozen different disorders in the DSM. But the issue about its effectiveness with people who have depression, while there's some disagreement in terms of some of the details, the American Psychiatric Association takes the position that for the mild version of depression, psychotherapy is probably the approach of choice. For the more severe of the depressions, they recommend the medications. Now, I personally think that many psychiatrists would take the position that if psychotherapy can reach the patient's problems, if it can reduce the distress, if it can reduce the disability, then it's preferred, because it's more likely to provide the patient with long-term tools that can prevent it from coming back. A lot of the problems that Allan has hinted at, Sascha hinted at too, is actually non-psychiatrists. The primary care physician has 7 or 8 minutes to spend with each patient. Not a lot of time. And a lot of the complaints can be seen as depression. And they are the ones who are prescribing the bulk of the antidepressive medications. But it is a substantial problem. The degree to which it's a placebo or not is a statistical debate that I'm really not prepared to be authoritative on, as to whether the milder don't benefit at all. That I think that most of the statisticians taking the position that actually even the mild version, probably the medications have some impact, but if the person can obtain psychotherapy, I think they'd be much better served.
Oh, the person can obtain psychotherapy. Yeah. So yeah. So it's amazing. I just have to say that having this experience right now, it's like that I get to sit next to you and have this conversation. You know, and I think that there's, you know, you seem like a really sweet, intelligent man. But I have to say, there's a lot of people who are really, you know, who see the DSM, the whole structure of the way the system is set up, see it as a huge problem. I mean, I feel like there's not, here I'll share with you one of the publications that you can download for free off our website. It's called The Harm Reduction Guide to Coming Off Psychiatric Medicine. And this thing has been translated into 6 different languages and is being used all over the world now. I think I am someone who takes psychiatric medication. I take a drug called lithium carbonate, and I've been taking it for 12 years, and it's extremely helpful for me. I think that there's a lot of people who get on psychiatric medication when they're young, and then have a really hard time getting off of it. And there's so much information about going on these fucking drugs, and then there's so little about coming off. And I guess I would just, I feel like there's so many voices that should be at this table in this conversation that we're having. And I know, you know, just knowing what I know from traveling around and having lots of conversations with people about this stuff, that there's a bunch of people in this room who this is a very personal issue for you, and that it's really hard to talk about. And I think we need so badly to be having more conversations, talking about the DSM, and also really just talking about how to take better care of each other.
I'm really glad you broached the topic of your guide for getting the Inverse Project's guide for coming off of medications, because we actually have another question that's oriented towards discussing medication in psychiatric treatment. So, in your opinion, are mental disorders overdiagnosed and are psychiatric medications overprescribed?
You might want to start with someone with
Sure.
Dr. Peele.
I can start with Dr. Peele.
I don't have an exact sort of answer to that. The question is, whether the individual is going to be served by the concept. Again, I'm not too interested in what's true. What epidemiologists will find when they survey people as to whether they have a disorder that fits into DSM-4 and the future DSM-5 or not. There's a lot of variances that depend on a person's interest, their willingness to, willing is not the right word, their interest in psychotherapy. There are jokes made about Woody Allen's being in psychoanalysis for decades. Springsteen, in the New Yorker article recently, talks about the fact that psychotherapy has made it possible for him to become who he's become. Whether either one of them has a mental disorder or not, I don't know. But the question is so individualized relative to the labeling that I find it hard to say whether there's too much or there's too little. But Allan did brush an issue that I do want to return to, and that is that the DSM should be respected, but it should not be worshipped. And the FDA, as Allan has inferred, some research organization, as Allan has inferred, are treating it as though it's the Bible, so that if you want a grant, for example, to work on a concept or a group of people who may not fit the DSM-4 neatly, it may not get approved. Probably won't get approved, as Allan says. That's unfortunate. Let me come at this from another angle. 56% of the DSM are entities for which we have no validity. The reason they're in there is not because we think they are true, or at least we can prove they're true. They're there because we want a common language. And that's what DSM-3 in 1980 accomplished, because the prior DSMs were very admirable in many ways, but there was no reliability. The two of you should examine me. There's a high chance in the old system that you come up with a different diagnosis. DSM-4 intended to change that. It moved towards reliability. But that doesn't mean that the way that 56% of the book that's not ideologically tied is the way nature has carved up psychopathology. We don't know how nature's carved up psychopathology. The reason that 56% of the book is in there, like major depressive disorder and so forth, is simply to create a common language so that when the patient comes into the office, you have some idea about what the experience is with of other clinicians with those signs and symptoms. But it doesn't mean that that's the truth. It's the way of organizing material so we can collect information.
Yeah, well, first, is mental illness overdiagnosed? I would say almost undoubtedly yes. That if you look at surveys of mental illness starting, say, in 1980 when the DSM-3 was established, you find a steady increase from prior epidemiological surveys. And if you look at the three most common disorders are depression, simple phobias, people who are afraid of little crawling animals, or heights would be the two most common simple phobias, and social phobias, people who are sort of nervous in public, nervous around other people. I think in every case you can attribute the reason for the great rise in the prevalence of these disorders to what Dr. Peele just mentioned, that the current psychiatric manuals just use symptoms, as they don't talk about the reasons for symptoms or the causes of symptoms, that the symptoms in themselves are reason enough to diagnose a mental illness. That is something new. That's something that has just been the case since 1980. So if you take depression, for example, there's lots of reasons why people would have the symptoms that would qualify them for a DSM diagnosis of depression, but sometimes they're very good reasons. I mean, if you just found out, if you wanted to get into medical school since you entered Pomona and you just got rejected from every school you applied from. Well, you're probably, at least for a while, going to meet the criteria for depression. But you don't have a mental illness, you're responding naturally. Likewise, for simple phobias, it's a somewhat different case. That is, it's pretty remarkable that the major things that people say they're afraid of aren't things that are dangerous at all. They're things like snakes and spiders. They're things like, say, flying in airplanes, thunderstorms, the sight of blood, all things that, when the human genome was forming, it was rational to be afraid of, but that pose no danger now. Obviously, well, flying obviously wasn't there, but being at a very high places, in enclosed spaces where there's no escape, that I think does strike evolutionary chords. But that this is almost a natural, if you're only looking at the symptoms, what you're seeing is disorder. What you're not seeing is that these may be sort of hardwired into the human brain. And while they're unreasonable, they're probably not dysfunctional. So that if you're only looking at symptoms, as since the DSM-3, the psychiatric manuals focus on and have the positive effect of better reliability, but again, very little validity. And I think that is one major reason for the increase in seeming mental disorders.
All right, so this whole idea of objective science to be able to talk about mental disorders, I feel like we need to just step outside the paradigm that we're talking in and just realize that it's rooted in these very Western ideas that don't necessarily correspond to how the rest of the world thinks about things. It does now because we're so powerful that we've managed to spread it across the rest of the world. But I think sometimes when we talk about human suffering and when we talk about the kind of the existential questions that people have been grappling with for a very long time, I think using brain chemistry as a metaphor is just so lacking. It's, there's a guy named Ethan Waters who wrote a book called Crazy Like Us, The Americanization of Mental Illness. And he looks at how pharmaceutical companies basically, went to other countries and figured out, for example, GlaxoSmithKline goes to Japan and spends an extraordinary amount of money trying to figure out how to convince Japanese people that depression exists. And they did, and then they sold Paxil to them. I mean, but it's all very well documented. And there's, he has a whole chapter about Zanzibar and how the traditional ideas of spirit possession got turned into this medical idea of schizophrenia. One thing that I think is really important to know when we talk about this stuff is that for a long time, organizations like NAMI would talk about how important it is, if we want to reduce the stigma against people with mental illnesses, we have to talk about how they're biological brain diseases. It's not their fault. It's not their fault that they're mentally ill. And then as it turns out, it doesn't actually work like that. The way it works is that if you think someone is mentally ill because of a biological brain disease, you're way more likely to stigmatize them. So anyway, here's this quote from Ethan Waters, which I think is very thought-provoking. "We are investing great wealth in researching and treating mental illness, medicalizing ever larger swaths of human experience, because we have rather suddenly lost older belief systems that once gave meaning and context to mental suffering." So there you go. I mean, I feel like that's put this conversation in a context that modern biopsychiatry, 1980. 1980.
Dr. Peele, would you like to respond?
Shasta brought up an important memory for me. When he points out that NAMI wanted to emphasize that it was not the fault of the parents that people had schizophrenia. When I came into psychiatry, we were doing a terrible thing. the parents would come to us as to why their 18-year-old son had schizophrenia. And they would ask, how come Johnny has schizophrenia? And they would be told, in one way or another, that it was a result of unfortunate parenting at a very early age. So they not only had to live with the fact that Johnny might not ever get better, but they also were given the concept that it was their fault. So, and when I used to present a patient in the early 60s to a faculty member, and I didn't find this early unfortunate parenting, I'd be told to go back and try to get a better history. So you can understand that with that climate, NAMI would be very interested in hooking onto a concept that the brain is, that there is a chemical imbalance. But I'm not so sure that that concept is needed anymore. I don't think we're blaming parents anymore. And so I think that, I'm sure that there are some clinicians, especially primary care docs, who feel that they get better compliance, et cetera, and for one reason or another, the concept of abnormal brain chemistry is a useful concept. But I don't find it useful, and I don't think many psychiatrists do, because they know that the evidence isn't there. The chemistry is simply not abnormal. On the phobia issue, again, it's an issue. Keep in mind that the definition of mental illness requires clinically significant distress or disability. Somebody who would react to snakes in certain settings, that might be a problem for them. But for most people in Manhattan and so forth, it is not, and therefore it is not a mental illness.
Well, just a couple things. One, with chemical imbalance, while I think it's absolutely true that there's very few psychiatrists who would now think of that as a primary cause of mental illness, if you're right, but it is pushed relentlessly still in pharmaceutical ads, that you can't escape that. And I think that it's entered the culture, and that even though the medical establishment no longer thinks that it's much of a credible theory, that many, many people do now accept it as a theory, even though. And so it's very much a culturally popular, if not professionally popular theory. In terms of over-medication, that we've sort of been focusing on overdiagnosis, then I think there's probably a difference between medications that people are choosing to take, however rightly or wrongly, and certain populations that have no choice in taking medications. And here, I'm thinking, especially among children, that younger and younger children are now being given very powerful and antipsychotic medications. I think that is one of the most worrisome trends in recent over-medication. And at the other end of the life cycle, that the rate of medicating very old people in nursing homes has been increasing spectacularly, not to make them well in any sense, but as a means of social control, as a means of controlling their behavior. So I think that over-medication is especially, not exclusively, but especially a problem among the young and the very old.
I want to go back to this this question of NAMI and how the whole thing developed. I mean, I guess I'll just explain to you from my perspective, you know, what I lived through. You know, when I was 18 years old, I was locked up for the first time and, you know, diagnosed bipolar. And there was this organization, NAMI, that was around, that was right there for my mom to find, you know, support from. And they had this class that my mom got to go to where my mom learned all about mental illness and about the mental illness that her son had, and how basically that I had a biological brain disease and that I needed to take drugs for the rest of my life. you know, it's really interesting. It was years before I came to understand the social, political background of how NAMI came into being, and that there was this horrible thing going on where parents were being blamed for their children. But you know what ended up happening is that a ton of drug money went into fueling this advocacy organization, and then they ended up basically, I mean, they've created a monster. I mean, because think about it, you know, sure, you don't want to be blamed for your child's illness, you don't want to be blamed for your child's problems, but people have a lot of problems at home, and if it sounds really nice to be like, oh yeah, you know, it's not my fault, you know, it's not my son's fault, you know, he's just mentally ill, when in fact, quite often, yeah, like parents are to blame for their children's issues. I mean, you know, it's complicated, but you know, you can't reduce it all down to brain chemistry. That's ridiculous.
Okay, let's narrow the discussion slightly to the DSM and how the DSM diagnoses and defines mental illness. So I want to ask, in what ways is the DSM, and particularly DSM-5, successful in defining and diagnosing mental disorders in a naturalistic way? And in what ways do those diagnoses seem artificially imposed? If you will, please consider the DSM's use of discrete categories, its emphasis on symptoms, which we mentioned previously, and the high rate of comorbidity, which is to say the high rate of patients that are diagnosed with more than one disorder.
Well, as has been mentioned before, that psychiatry really had a revolution in diagnosis in 1980. Before 1980, psychiatric manuals were just not a very important part of the profession. There were these little things in spiral binders that psychiatrists and other mental health professionals didn't pay much attention to. The definitions really were very short and cursory. Nobody really used them. So these were fine for clinicians because clinicians really didn't need to use them. Diagnosis wasn't a major part of psychiatry. This all changed with the DSM-3 in 1980 because if psychiatry was going to be a legitimate medical specialty, legitimate medical specialties treat illnesses, treat diseases. Psychiatry needed specific categorical diseases to become a respected medical specialty. And this is what the DSM-3 very successfully did. Also, as I mentioned before, now mental health professionals, to get third-party payments, need diseases. Patients need diseases to get treatment. There's lots of interest in having diseases. The problem is that these diseases have very little validity. They don't, as also has been carved nature at its joints. And I think the DSM-5, the committee initially recognized this. They had planned for a major overhaul of the diagnostic system because they knew it was really inadequate. Well, I think the paradox is, in 1980, the researchers imposed the system of the DSM-3 on the clinicians. The clinicians resisted unsuccessfully. The researchers won. For the DSM-5 that's scheduled to be published in May, the situation has reversed itself. The researchers now recognize that the diagnostic criteria are really inadequate. But the clinicians have been rebelling against the major suggestions because they're afraid that they'll lose their reimbursement. They're afraid that it's going to be too complicated to introduce major changes. So now it's almost the reverse of the situation in 1980, where the researchers imposed the diagnoses on the clinicians. Now the researchers are trying to change the diagnoses. The clinicians are resisting the major changes, and it looks as if the clinicians are going to win, and the DSM-5 really is not going to be a tremendous change from the DSM-4 and the DSM-3 as was initially envisioned.
Dr. Peele?
Allan's raised a number of major questions, and I'm just going to take on some of them, but I certainly want to get back to his point about the validity of the diagnoses. But historically, you know, DSM-1 and DSM-2 are usually written off as not of any significance in the field, and nobody ever bought them and so forth. Actually, DSM-2 was the American Psychiatric Association's bestseller for years. And also, I want to read you the definition of schizophrenia. Now, this will be more relevant to those of you who happen to know DSM-3's definition, but I want to read you DSM-1. It represents a group of psychotic disorders characterized by fundamental disturbances in reality relationships and concept formations with affective, behavior, and intellectual disturbances in varying degrees and mixtures. The disorders are marked by strong tendency to retreat from reality, by emotional disharmony, unpredictable disturbances in streams of thought, regressive behavior, and in some, a tendency to deterioration. Now that definition, that picture of schizophrenia is richer and more informative than DSM-3's pick 2 of 5. But it has a big problem. Two of you could be examining me as to whether I had schizophrenia on that basis of the DSM-1 description, and there's a high or at least a strong probability you would not agree. And that lack of agreement was what led to a different way of diagnosing in psychiatry. Most medicines, descriptions, whether you pick up Merck Manual or what have you, they describe a prototypical, that is a typical presentation of the illness. And what I just read you is the kinds of definitions that you will see in most of medicine. But the reliability was bad. So when they moved from this prototypical to a criteria set, in which it says you can't be diagnosed if you haven't had the illness for 6 months, and so forth. Very artificial to increase the reliability. Now it is possible that in DSM 6, 7, or 8 in the future, the psychiatry will return to the prototypical approach and abandon the DSM-3 criteria approach because they'd like to get closer to what they really perceive an illness to be. Allan brought up another key, and this I want to run over, but this is just too big an issue for me to not emphasize. Allan has pointed out that there's a big problem in the way that 56% of the DSM-3, 3R, and 4 are conceptualized, and that's going to remain with DSM-5. But as Allan has suggested, that may be psychiatry's biggest problem. We have not been able to figure out a better way to do it. Now, there are a lot of new minds and fresh minds in this room, and it would be extremely helpful if there was a totally different way of looking at psychopathology so that psychiatry could get out of this being stuck ever since DSM-3 came out. There's practically been nothing new. There are a few more dimensions, a few more sleep disorders, but there's nothing new in terms of etiology. And it's partly because of what Allan has said. DSM-3's construction of psychopathology is such the field can't seem to move. And Allan's point is an extremely crucial one. We've got to figure out. But the reason that the dimension approaches and others that Allan has hinted at are not accepted because they don't solve the problem. We agree that the field is stuck, but we haven't heard how to get unstuck.
So, two ways to approach this. I'll just start off and say the straight up thing that wants to come out of my mouth. What hasn't been mentioned yet is that, and I have this paper here, nearly 70% of the DSM-5 task force members report having ties to the pharmaceutical industry. I mean, I feel like we just have to talk about, we're having a conversation about how to diagnose people. And I take it really personally, because me and a whole bunch of my friends are all people who have these intense diagnoses. I have a diagnosis that's like, they say it's a serious and persistent mental disorder, and I have to wrestle with that. There's other people in this room that have that as well. We have to wrestle with that. I mean, I feel like language is very powerful. The words we choose to use to talk about ourselves and to talk about other people have a really big effect. I think it's really important to be asking, who are the people who are coming up with these decisions? Like, who makes the decisions to decide to cause? You know, like, I feel like when we started the Icarus Project 10 years ago, you know, one of the first questions that we started with was this question of, well, if we don't trust society to decide for us, you know, that we are sick or we're healthy, what criteria are we going to use as individuals and as a community? How do we decide for ourselves what's sick and what's healthy? And I feel like that's just a really important, I bring that to the conversation because I feel like really the DSM it's a business tool. I mean, it's something that's used. My friends who are therapists, my friends who are radical social workers who are actually out there in the field who are doing work, they diagnose people with PTSD and with depression or otherwise specified. They diagnose people with things where it's not going to end up on their record and they can still get the benefits. You know, you learn how to use the tool to work for you. You learn how to use the system. And so it's super interesting to be sitting up here and having this conversation, you know, with someone who's like on the DSM-5 task force. But I just want to point out that on some level, you know, it's important to think about the politics and the economics of it and stuff, but we actually have to, for those of us who actually have to wrestle with this language ourselves, we have to also figure out how seriously we're going to take it. And if 70% of the people who are on the DSM-5 committee are taking money from the pharmaceutical industry, I'm not going to take it too seriously. Thank you.
Would either of you like to respond?
The 70% figure is accurate relative to the past, but the APA did realize that had to change. So none of the members of the DSM-5 task force that I'm on gets much money. I think most of us get none, but there was a limit of 10,000 a year relative to members of the task force or the work groups or anybody else who's making decisions about what is in DSM-5. You will see some people who are connected to pharmaceutical firms in the list of 1,000 names or so that are going to be in DSM-5 that contributed to the process, but nobody who made money beyond 10,000 is allowed to be part of the decision-making process as to things like criteria sets. But 70% is certainly accurate relative to the past. There's another angle. Shasta, I'm sorry, you printed out that slip away from me.
I'm sorry, I just have to say, this is from this paper from a couple years ago. Unrestricted research grants were excluded from the APA's disclosure requirements, even though the monies from such grants could total hundreds of thousands of dollars or more. There are also no policies for managing indirect financial ties, such as industry funds that are pooled and given to academic departments, hospitals, and medical schools. Moreover, DSM panel members are allowed to resume their financial relationships with industry as soon as the tenure on the DSM panel is over. Thanks.
I would point out that probably the two most prominent critics of the DSM-5 were both psychiatrists. One, the head of the DSM-3 task force, Robert Spitzer, and especially the head of the DSM-4 task force, Alan Francis, who has been, so they've both been very vociferously against what the DSM-5 task force has been, despite themselves being very eminent in the earlier processes. But just did want to comment, because I don't think it's been said yet, why diagnosis and diagnostic manuals in psychiatry really have an outsized place compared to any other medical specialty. As you just wouldn't have this kind of conversation going on among cancer doctors or with asthma, with diabetes, because psychiatry doesn't have anything other than the diagnostic criteria to define its disorders. That is, there are no independent tests. There's nothing equivalent to an X-ray, to a biopsy, to blood tests that other medical specialties have, so that the criteria themselves really take an all-important place in psychiatry, which is why I think the the DSM-5 and the DSM itself is such an important document and really unique document among all medical specialties.
And let's move on to our last question. We discussed a lot of problems with how we currently define and diagnose mental disorders and with the DSM and the APA in particular. But what do you think psychiatry and psychology can do to better their reputation with patients and with the public at large? And on a related note, what can clinicians do to improve public understanding of mental illness and help reduce stigma? Feel free to jump in.
It's interesting because I've spent a lot of years outside thinking about how to do things from the outside. Maybe what I'll do, this is like this, I'll just read this. I wrote it. When I think about solutions to this mess, I envision a vibrant social and political